Welcome. Today's class is on guidelines for gallstone prevention. To begin with, disorders of the biliary tract affect millions of people each year, causing significant suffering and even death by precipitating pancreatitis and sepsis. The common diseases of the biliary tract are cholelithiasis, the formation of gallstones in the absence of infection of the gallbladder; cholelithiasis, the presence of gallstones in the common bile duct; and cholecystitis, the inflammation of the gallbladder. Other diseases include primary sclerosing cholangitis, primary biliary cirrhosis, and bile duct cancer. Treatment may involve diet, medication, or surgery. Objectives include to understand the physiology, functions, and disorders of the gallbladder, and to learn the measures to prevent gallstone formation with special reference to diet. Physiology and functions of the gallbladder involves the biliary tract consists of gallbladder and the bile ducts. The bile ducts carry bile and other digestive enzymes from the liver and pancreas to the duodenum. The gallbladder is a small pouch-like organ that lies on the undersurface of the right lobe of the liver. The main function of the gallbladder is to concentrate, store, and excrete bile, which is produced by the liver. During the concentration process, water and electrolytes are reabsorbed by the gallbladder mucosa. The chief constituents of bile are cholesterol, bilirubin, and bile salts. Bilirubin, the main bile pigment, is derived from the release of hemoglobin from RBC destruction. It is transported to the liver where it is conjugated and excreted via bile. Bile salts made by liver cells from cholesterol are essential for the digestion and absorption of fats, fat-soluble vitamins, and some minerals. Excreted into the small intestine via bile, bile salts are then reabsorbed into the portal system. In addition, it is the primary excretory pathway for the minerals like copper and manganese. Bile is removed by the liver via bile canaliculi that drain into intrahepatic bile ducts. The ducts lead to the left and right hepatic ducts, which leave the liver and then join to become the common hepatic duct. The bile is directed to the gallbladder via the cystic duct for concentration and storage. The cystic duct joins the common hepatic duct to form the common bile duct. The bile duct then joins the pancreatic duct, which carries digestive enzymes. During the course of digestion, food reaches the duodenum, causing the release of intestinal cholecystokinin and secretin. This stimulates the gallbladder and pancreas and causes the sphincter of Oddi to relax, allowing pancreatic juice and bile to flow into the duodenum at the ampulla of water to assist in fat digestion. For this reason, diseases of the gallbladder, liver, and pancreas are often interrelated. Now, let's see the diseases of the gallbladder. 1. Cholelithiasis. It's the formation of gallstones in the absence of infection of the bladder, which is called as cholelithiasis. Virtually all gallstones form within the gallbladder. With rare exceptions, stones form behind biliary duct stricture as a result of stasis in bile ducts after cholecystectomy. Gallstone disease affects millions each year and causes significant morbidity. In most cases, gallstones are asymptomatic. However, symptomatic gallstone disease can have serious complications. Now let's see the causes. According to the Harvard Health publications, the bile components may crystallize and harden in the gallbladder, leading to the formation of stones. 80% of gallstones are made of cholesterol, and the remaining 20% of gallstone comprises of calcium salts and bilirubin. These are called the pigment stones. Bilirubin is formed during the destruction of RBCs. In some cases, like cirrhosis of liver, results in excessive bilirubin. This in turn cannot be broken down by the gallbladder, resulting in stones which are small and dark, called the pigmented stones. Next, cholesterol stones. These are light yellow to dark green or brown or chalky white in color, about 2 to 3 cm long with tiny dark central spot. Bile has the capacity to dissolve or break down the cholesterol secreted by the liver, but when the produced cholesterol is higher than normal, cause the development of heart stones. Concentrated bile, normally the gallbladder empties the bile to function properly. Disturbances in this function results in concentration of the bile, causing stone formation. The next cause is bacteria, which may also play a role in gallstone formation. Low-grade chronic infections produce changes in the gallbladder mucosa which affect its absorptive capabilities. Excess water or excess bile acid may be absorbed as a precipitate out and cause gallstone formation. High dietary fat intake over a prolonged period may predispose a person to gallstone formation because of the constant stimulus to produce more cholesterol for bile synthesis required in fat digestion. Next reason is the genetics and increased weight. This may also predispose to gallstone formation. The symptoms of gallstone include the gallstone that pass from the gallbladder into the common bile duct may remain there indefinitely without causing symptoms, or they may pass on into duodenum with or without symptoms. Cholelithiasis develops when stones slip into the bile ducts, producing obstruction, pain and cramps. If passage of bile into the duodenum is interrupted, cholecystitis can develop. In the absence of bile in the intestine, lipid absorption is impaired, and without bile pigments, stools become light in color. If uncorrected, bile backup can result in jaundice and liver damage. Obstruction of the distal common bile duct is blocked. Gallstone attack the pain in the right upper quadrant of the abdomen that often radiates to the back or right shoulder to shoulder blade. The pain persists from 30 minutes to several hours, especially after fatty meals. 80% are asymptomatic, called the silent gallstones according to the American College of Gastroenterology. The next symptoms are fever, then jaundice with yellowish tint to the skins and eyes, nausea, vomiting, clay-colored stools, digestive problems including bloating, indigestion, heartburn and gas. The risk factors include, the risk factor for cholesterol stone formation include pregnancy, older age, family history, obesity and truncal body fat distribution, diabetes mellitus, inflammatory bowel disease and drugs. Certain ethnic groups are at greater risk of stone formation. Rapid weight loss is associated with a high incidence of biliary sludge and gallstone formation. The risk factors associated with pigmented stones are age, sickle cell anemia and thalassemia, biliary tract infection, cirrhosis, alcoholism and long-term parenteral nutrition. Consumption of high fiber diet with high fat or cholesterol diet is one of the cause. Rapid weight loss in short period of time is also another reason. The non-vegetarians having 9 times increased risk when compared to vegetarians. Nutritional factors like few meals per day, constipation, decreased intake of folate, magnesium, calcium and vitamin C. Female gender, due to increased estrogen level that increase the cholesterol level in bile and thereby decreases the gallbladder contractions. Hormone replacement therapy may also be a reason. Lack of melatonin may be a reason for gallstones, as melatonin inhibits the cholesterol secretion from the gallbladder, enhances cholesterol conversion into bile, and it is an antioxidant that decreases the oxidative stress of gallbladder. erythropoietic protophilia, and prolonged use of pump inhibitors also decreases gallbladder function. The diagnosis of gallstone includes increased bilirubin results in jaundice causing yellowish tint of skin and eyes, ultrasound, abdominal CT scan, gallbladder radionuclide scan, magnetic resonance cholangiopancreatography, cholecystography, and blood tests are commonly used for diagnosing gallstones. The complications include, in some cases, the gallstones result in various other complications where it causes severe blockage or move into other parts of the digestive system. Next, cholecystitis. This is inflammation of the gallbladder is known as cholecystitis, and it may be chronic or acute. It is usually caused by gallstones obstructing the bile ducts, leading to the backup of bile. Bilirubin, the main bile pigment, gives bile its greenish color. When biliary tract obstruction prevents bile from reaching the intestine, it backs up and returns to the circulation. Bilirubin has an affinity for elastic tissues. Therefore, when it overflows into the general circulation, it causes the yellow skin pigmentation and eye discoloration typical of jaundice. Next is the acute cholangitis. When the bile becomes obstructed, it is prone to various infections from bacteria. The symptoms of acute cholangitis include pain in the upper abdomen that travel towards shoulder blade, increased temperature, jaundice, chills, confusion, and itchy skin. Patients with acute cholangitis need resuscitation with fluids and broad spectrum antibiotics. If the patient does not improve with conservative treatment, placement of a percutaneous biliary stent or cholecystectomy may be required. Then cholestasis. Cholestasis is the condition of sludge-like buildup in the gallbladder as a result of stimulation or release of bile. This can occur in patients without oral or enteral feeding for a prolonged period, such as those requiring parenteral nutrition, and can predispose to acalculous cholestasis. Prevention includes stimulation of intestinal and biliary motility and secretions by at least minimal enteral feedings. If this is not possible, drug therapy is used. Next comes acute pancreatitis. Acute pancreatitis has numerous causes, among which gallstones is a major one. Pancreatitis is an inflammation of the pancreas, and it is characterized by edema, cellular exudates, and fat necrosis. The disease can range from mild to self-limiting to severe, with autodigestion, necrosis, and hemorrhage of pancreatic tissue. The symptoms of pancreatitis can range from continuous or intermittent pain of varying intensity to severe upper abdominal pain, which radiates to the back. Symptoms worsen with the ingestion of food. Clinical presentation may also include nausea, vomiting, abdominal distension, and steatorrhea. During acute attacks, all oral feeding is withheld and hydration is maintained intravenously. In less severe cases, a clear liquid diet with negligible fat may be given in a few days. The diet should be progressed as tolerated to easily digested foods with a low fat content and then advanced as tolerated. Food may be better tolerated if they are divided into 6 small meals. Next comes the cancer of the gallbladder. Cancer of the gallbladder is a very rare but serious complication of gallstones. Abdominal pain, increased temperature of 38 degrees Celsius or above, and jaundice are the common symptoms. This can be treated with the combination of surgery, chemotherapy, and radiotherapy. Next is the Gallstone Ileus. The other rare but serious complication of gallstones is when the bowel becomes obstructed by a gallstone, leading to Gallstone Ileus. In this, an abnormal channel known as fistula opens up near the gallbladder. Gallstones move through the fistula and block the bowel. This causes symptoms like abdominal pain, being sick, swelling of the abdomen, and constipation. This condition requires immediate treatment as the gallstone may rupture the bowel, causing internal bleeding and infections. Surgery is the usual procedure done and the gallstone is removed. Next comes the cholelithiasis. It is a complication of cholelithiasis where the stones are in common bile duct. The liver function blood test shows an increase in bilirubin and serum transaminases and raised indicators of ampulla of Vater such as lipases and amylase. The medical management involves the treatment of gallstone disease, mainly surgical removal of the gallbladder, especially if the stones are numerous, large or calcified. Cholecystectomy may be done as a traditional open laparotomy or as a less invasive laparoscopic procedure. Chemical dissolution with the administration of bile salts, quinodeoxycholic acid and ursodeoxycholic acid, or dissolution by extracorporeal shock wave lithotripsy may also be used, but these are much less common than surgical techniques. Patients with gallstones that have migrated into the bile ducts may be candidates for endoscopic retrograde cholangiopancreatographic techniques. Next, let us see on the medical nutrition therapy. No specific dietary treatment is available in susceptible persons. Nutrition related factors include obesity and severe fasting, and these should be corrected when possible. In cholecystitis, dietary treatment includes a low-fat diet to prevent gallbladder contractions. After surgical removal of the gallbladder, oral feedings are usually resumed with the return of bowel sounds and after the patients can tolerate nasogastric drainage tube removal. The diet can be advanced as tolerated to a regular diet. In the absence of the gallbladder, bile is secreted directly by the liver into the intestine. The biliary tract dilates, forming a stimulated pouch over time to allow bile to be held in a manner similar to the original gallbladder. If patients are obese, some weight loss before surgery is advisable. Thus, the supportive therapy is largely nutritional. Fat is the principal cause of contraction of the diseased organ and the consequent pain. It must be greatly reduced to 20 grams per day and energy should be derived chiefly from carbohydrate. The prevention of gallstones involves, first one is balanced diet. In cases where surgery is not the mode of treatment, the diet plays a vital role. This involves consumption of a well-balanced diet and it is also essential for prevention of gallstone formation. During acute attacks, no food is given to rest the system. Gradually, the patient is given clear fluid followed by soft fiber restricted low-fat diet. Skipping meals must be avoided. Regular meal timings must be strictly maintained. Small frequent meals must be preferred over normal 3 meals a day system. As such, the fat as in monounsaturated which is present in olive oil, canola and polyunsaturated fats in avocados, canola, flaxseed and fish oil may lower the risk of gallstone formation. Saturated fats must be avoided as it may increase the chance of gallstone formation. Fiber. Foods with moderate amount of fiber can be included as it may help in reducing the weight and prevent gallstones. Fruits and vegetables, mainly the gas producing or irritating foods, must be limited. At least 5 portions per day is suggested. Nuts like peanuts, almonds and walnuts may also prevent gallstones. The carbohydrates which are converted into sugar, hence the consumption of refined forms of carbohydrates may increase the risk of gallstones. So that must be limited. Next is lecithin. Studies have found that lecithin present in a number of foods like soybean, oatmeal, egg, milk, peanuts, cabbage and chocolate prevents gallstones. This lecithin keeps the cholesterol from solidifying in the gallbladder. The next important is body weight maintenance. Obese patients are found more likely to suffer from gallbladder diseases. Hence, losing weight and maintaining normal weight is suggested for those who are susceptible to this condition. Overweight and obese patients have an increased amount of cholesterol in the bile, but low calorie, rapid weight loss diets must be avoided, and the weight loss must be slow and gradual, as it might disrupt the bile chemistry, thereby increasing the risk of gallstone formation. Regular exercise plays an important role in preventing the formation of gallstones. Normal exercise like walking, jogging, swimming, etc. can be preferred. 30 minutes 5 times a week is required to make a difference and maintain the weight within the normal levels. Medications. The consumption of certain drugs or medication therapies may increase the risk of gallstone formation. Cholesterol lowering drugs, some drugs which are used to lower blood cholesterol such as Lopoid and Tricol increase the risk of gallstone formation. And it is because it increases the amount of cholesterol released in the bile. Hormone therapy, mainly the hormone replacement therapy taken by women, may increase their risk of developing gallstones, as the estrogen causes the body to produce excess cholesterol. Next, let's see on foods to be included. Cereals in soft form, cooked rice, chapati, bread, idli, milk pudding, milkshakes, curds, cooked or pureed vegetables, khichdi, porridge, fruit juices, fish and chicken, soft cooked eggs can also be given. These are high calorie, high protein foods which helps in regenerations of liver cells. Next, let's see the foods to be avoided. Mainly fried foods, high fat meats and dairy products like cheese, cream, foods made with butter or margarine, oils and high fiber foods, and gas producing foods like whole grain breads, nuts, broccoli, cauliflower, cabbage, etc. and spicy foods too. To summarize, cholelithiasis is a formation of gallstone in the absence of infection of the gallbladder. A balanced diet with low fat, high calorie, high protein for regeneration of damaged cells is recommended with regular exercise and maintenance of normal weight. Thank you.